of Fertility New Zealand, and it's my absolute pleasure to open this evening's session. Our webinar tonight is brought to you by two wonderful charities which have both worked for many years to support New Zealanders through really difficult challenges of their life. So Fertility New Zealand and Endometriosis New Zealand both have a range of resources and support available, and I really encourage you to reach out and make the most of everything that they have to offer. I know Deborah will talk a bit about what endometriosis offers, and Fertility New Zealand has support groups if you would like to meet others in the same boat experiencing infertility. We have volunteers running groups in 12 places around the country. So tonight we're really fortunate to have two wonderful speakers. We have Professor Neil Johnson. He is Fertility Specialist and Director of Research at Repromed in Auckland, and also President of the World Endometriosis Society. We also have Deborah Bush QSM, who is CEO of Endometriosis New Zealand and also Director of EPP Consulting. So they will both collectively give a presentation of about half an hour. And at the end of that presentation, please feel free to type your questions into the chat box and they'll be answered on screen by our two speakers. So without further ado, it's my absolute pleasure to hand over to Neil and Deborah, and it will be Neil that will be speaking first. Thank you.
Thank you, Nicola, and good evening, everybody. Just like to thank you, Nicola, for arranging this evening, and to thank Fertility New Zealand, and to say a good evening to everybody, and hope that you're getting back to your new normal, emerging from the post-COVID lockdown, which has been challenging for everybody, and I think particularly challenging for many of my patients who have endometriosis, both from the pain and symptoms perspective as well as from the fertility perspective. So it's very nice to be getting back to normal. We don't have a lot of time, so I'd like to cut to the chase and just say what endometriosis is. Well, it's the presence of functioning endometrial type tissue outside of the uterine cavity, and as you can see, it's on the various important structures that you see highlighted there, and it causes inflammation of these tissues as a result, and perhaps most importantly, causes pelvic pain or infertility or both. Now I'm sorry, Nick. Oh, sorry, I beg your pardon. I did know how to operate the technology. So the symptoms of endometriosis, we've said infertility, and we'll come back to that in a moment. But pain is really a big problem, and I know that Deborah will be speaking more about this. Also, bowel problems. Sometimes endometriosis can be quite asymptomatic or silent, and quite commonly only comes to light through the investigation of otherwise unexplained infertility. It can be suspected because of certain features on examination, as well as importantly through imaging. And although we're saying here that it can only be really reliably diagnosed through laparoscopic visualization, I think more and more we're recognizing the importance of imaging, of ultrasound, and even of MRI in actually positively diagnosing in a non-invasive way the presence of endometriosis. And another marker that can sometimes be useful is the CA125 blood test. So for a woman of reproductive age, far and away the commonest cause of elevated CA125 would in fact be endometriosis. But yes, the one, I suppose, most accurate and reliable way of diagnosing it is through a laparoscopic procedure, which if we're doing our job properly, will lead us onto treating it surgically. But first of all, before we talk about this, what happens to the endometrium, firstly in normal women, and secondly in women with endometriosis? Well, as you will know, the endometrium grows and develops on the inner aspect of the uterus. This is the important bit that is the receptive bit to the embryo implanting into it. And this happens as part of the normal menstrual cycle before, if there's no pregnancy on this cycle, it's shed. The same thing, of course, happens to these lesions, which are occurring outside of the uterus, on the ovaries, and in the areas close to the uterus. So again, under the influence of hormones, the endometrial type tissue grows and develops. There is also often some bleeding associated with this, as we see with a normal menstrual bleed. But this happens inside the pelvic cavity and sets up an abnormal inflammatory reaction to this tissue. So it can cause scarring and adhesions and distortion of the anatomy. And this is the kind of thing that you can end up with. It can be very subtle, such as this lesion, which is just like little vesicles of the superficial or peritoneal layer. Sometimes it can cause just little pouches, as here in the cul-de-sac or pouch of Douglas behind the uterus. Sometimes you can get more classical flare lesions, as you see here. And often deeper nodular kind of endometriosis. These are the ligaments. You may have heard of the uterosacral ligaments behind the uterus, which is up here. And then sometimes you can get stage 4 endometriosis, which is where endometriotic cysts or endometriomas form. There's scarring, so there's no clear pouch behind the uterus. The cul-de-sac or pouch of Douglas is obliterated here, and we see quite nasty, extensive endometriotic lesions. Now, this obviously is the type that is most associated with infertility, but any type or extent of endometriosis can be associated with pain, and I think Deborah will mention this also later. So, what treatments do we have? Well, I've mentioned surgical, laparoscopic surgical removal, and that's important. It's important from the fertility perspective, and it's also important from the perspective of relief of pain symptoms. But also medical treatments are important, and we've mentioned progestin hormones here. Also, the combined pill is a hormonal treatment option. GnRH agonists such as Zoladex and newer treatments such as GnRH antagonists, and some of you may be aware of trials of elagolix and relugolix that we've been involved in doing in New Zealand recently. So these are shortly to come to the market. But the problem with these hormonal treatments is that they're very effectively contraceptive. So for women wanting a pregnancy, these are not such great options. Good options for symptom control, but for fertility improvement, perhaps not. I mean, hopefully in the future we'll be identifying the exact pathological mechanisms and addressing those, but we certainly don't have this yet. So, why do women with endometriosis have more difficulty becoming pregnant? So I suppose in no particular order, these are the various mechanisms. And Nicola, I'm very pleased to see that you've put first that the endometrium, this is the normally placed endometrium, not the endometrial type tissue outside of the uterus. This might be less responsive to an embryo that's trying to implant into it. And I'll come back to that shortly. Yes, it's true that sex and the pain related to sexual activity could be a big deterrent, particularly at the time of ovulation. So this is another mechanism through which endometriosis causes infertility. The fallopian tubes and ovaries could be scarred and even blocked as a result of inflammation. And also the ectopic endometrial type tissue in the pelvic cavity, it produces chemicals such as cytokinins, and this alters the intraperitoneal environment, the environment in which eggs are growing and into which they're released before they're picked up by the fallopian tubes. And it can also have a negative impact on sperm transport or on fertilization. Yes, we've mentioned sometimes it can be an anatomical issue, but this is the more extreme variation of endometriosis that scars the fallopian tube completely and makes it impossible to pick up the egg. There are also, of course, impacts on ovarian reserve and more subtle impacts of the inflammation caused by endometriosis on fertility. I'm just going to briefly mention a patient who contacted me through the Repromed website. This was actually a couple of years ago now, in June 2018, and I got an email from Kerry, pictured here with her husband Dan and her son Alex, 4-year-old son. So I'll just let you read what the email said, and I was just reading this online. And of course, even before COVID-19, I particularly, because of my special interest in Lepardol and Lepardol hysterosalpingograms and the fertility impact of this, have been doing a lot of telehealth consultations for patients around New Zealand and also patients from overseas. And as you'll see, Kerry is from Washington State in the US, and she was 35 years old and had primary infertility, so she'd never been pregnant for 14 years. So hopefully you'll have had a chance to read her story. So we did a telehealth consultation, and she came to New Zealand, had a Lepardol procedure, and amazingly, this was a communication that I got from her immediately on arriving home. So don't underestimate the value of a good holiday to New Zealand for one's fertility. So this was really quite an amazing outcome. After 14 years of primary infertility, she had the Lepardol procedure, which is an HSG technique, so the X-ray dye technique for the fallopian tubes. I think many of you will know what a hysterosalpingogram is, and it's fairly low invasive. I'd call it a reasonably low invasive procedure by the standards of many of the things that we can offer to our patients. And then over the course of time, over the next 9 months, we saw some beautiful pictures. And then finally, we got this wonderful email showing a very tangible cure for primary infertility through the use of a Lepardol hysterosalpingogram with the birth of baby Amaryllis. So this was just a delight for this American family. And so really this is just an illustration of how well sometimes, and how surprisingly well, Lepardol can work. So Lepardol, which is a poppy seed oil derivative, and we call it endometrial bathing and tubal flushing because Lepardol is an effective flusher of debris from fallopian tubes that's perhaps not blocking them, but that is hindering fertility. But there's also an immunobiological reaction to the Lepardol, this oil-soluble contrast medium that we use at the time of the HSG, and we've become aware through our own data that it is particularly effective for the fertility of women with endometriosis related infertility, and does seem to be working through an immunobiological mechanism. And we've got some growing evidence that it's working on the endometrium, so the receptivity, as we mentioned earlier on, of the endometrium may well be improved with Lepardol. The other options, I think many of you will know of these other options: intrauterine insemination, or IUI with ovarian stimulation. And in fact, to some extent, for many of my patients, Lepardol has given IUI a new lease of life. We've got some now good evidence that IUI works very well for couples with unexplained infertility or or endometriosis-related infertility where the fallopian tubes are normal, perhaps improving threefold one's fertility over 6 months if one goes for, say, 3 or 4 IUI cycles. And we've got Lepidol improving the fertility of women with endometriosis fourfold. So probably combining the two, having a Lepidol procedure and then perhaps alternating natural cycle attempts to conceive naturally with stimulated IUI cycles is a good idea. Of course, IVF is also a good option, and this gets around the issue of the intraperitoneal environment where the eggs are removed directly from the ovaries. Laparoscopic surgery improves fertility, although maybe not as much as we used to think that it did. And then also some women look at other treatments. Not that we're particularly promoting those through Repromed, but Deborah may have some mention of this. So we did a study to look at, what's the best fertility treatment for women with endometriosis-related infertility. We did a network meta-analysis, and I'm coming to my final slide. I apologize that it's a bit of a complicated slide, but it distills what we found in this study. And what we see up here, it's hiding on my slide, at least hiding behind my picture, but this is the comparisons that were made in this study. So this is all the world randomized trial literature, so all the best evidence of the fertility treatments. And this was a series of rankograms. But the important thing is this graph, and it's sort of it's a bit of a down under graph, because top of the league table is actually at the bottom. Now, you will notice that IVF and IUI are missing from this league table of what is the best treatment. And over to the right side of the line is where the treatments are more effective. So if it's clearly to the right side of the line, that means it's effective. So laparoscopic surgery, GnRH analogues, slightly to the right of the line, but laparoscopic surgery and this thing, pentoxifylline, which is I suppose it's an anti-inflammatory agent, and Lepidol. So I think the importance of the fertility improvement through damping down inflammation is seen here. But the trials haven't compared IVF and IUI with the other treatments, so they're missing from this. So we can't really claim that Lepidol is necessarily the best, but it's certainly well up there. So that was just a quick run through, and now it's my delight to hand over to you, Deborah, and I'm going to ask Deborah Bush to take it from here. Shall I just advance the slide?
Yes.
There we go.
Yeah. No, thank you, Neil, and thank you very much, Fertility New Zealand and Nicola, for inviting Neil and I to present tonight. I've got this beautiful slide here, and it says, endometriosis, what on earth can I do? When I say beautiful, I absolutely love this image, and I'd like to acknowledge the work of Ngahuia Murphy, who used this image in conjunction with Regan Balzer, who did this image for her study, her PhD. I also love this saying because I think it captures the essence of not just endometriosis, but fertility, and also just a woman's cycle, a flowing rhythm, an ancient ritual, Waifero, derived from the earth herself as she dreamed of the teeming multitudes of creation. And Waifero is, of course, the red waters of a menstrual period. So what on earth can I do? It's a beast of a disease. It can be really mean. So moving on to this, I absolutely know that so many of you have a really rotten journey to try and get help with endometriosis. You might start here and you aim to be up here, which is where, for me, wellness is. And so, but frequently it's a U-turn and it's around the corner and it's a back and try again and it's a start over and it's a what on earth now because I've reached a dead end, and it sometimes feels entirely hopeless trying to get the help that you need. And I've put this image here, not to be funny, although I think it is quite funny, but it really is like, why aren't my health professionals listening to me? And I used this one at Easter time because it had more relevance then, but I thought I would leave it in now. That so often that we know you're just simply not being heard, or your story feels like it's falling on deaf ears. So that is actually now, I want to show you this because in actual fact, if we put that now into the literature, that is exactly what happens. It's not just your story. It's not just the way you're feeling. It's not you being alone. The literature tells us, if we look at this image here, that from first presentation to a GP, and if we follow this round, actually this is the Endometriosis New Zealand logo, and I flicked it up the other way just to show you a journey, that by the time we get here to laparoscopic surgery, where endometriosis is finally diagnosed, on average right around the world, that's 8+ years. That's 8+ years of having the most terrible pain, of not being believed, of feeling forgotten, of having your work compromised and your relationship compromised, and maybe even also now that you're older, it's your fertility as well. And often we think, yay, I've finally got my surgery and everything's going to be fine. But when we consider the story and we look closely here, we can see if you've been in pain for 8+ years, often you might have been told you've developed a chronic pelvic pain condition, or you've got chronic pelvic pain, persistent pelvic pain sometimes, and that is not usually going to resolve from one surgery or from having the surgery and then you can get on. Because often if we talk about pain, that pain that is experienced on most days that has lasted longer than 6 months tends to be chronic pain, and that is more complex to treat. So let's now look at what that might be. When we talk about chronic pain, we think, why hasn't my pain resolved? I've had the surgery. In fact, you might have even been told that by doctors. Well, you've had the surgery. Let's investigate other causes. Let's also look up here to, is my pelvic pain being managed? Has it been assessed properly? And what can I do about my fertility now? I'd like us to just come back to the surgery. And was that performed by an advanced laparoscopic surgeon who practices the art of excision or removing the endometriosis? So we want best practice surgery naturally to be available to everybody in New Zealand, but I think to be fair, we don't say every dentist is an orthodontist. And likewise, we can draw a similar conclusion with a gynecologist. So we're really looking for someone with expertise in treating and managing endometriosis. And that might mean, great, that's a great place for you to start. You can start having a look around, and I'll show you where to go in a minute. So if we have a look at the next slide, I've actually addressed some of these things. If we put a big heart around these things, let's have a look at developing your health team. And you can actually get your notepad now or your phone, and you can write a list. Who's in this team? Who do I need? So here's some ideas for you that you can write down. So we've got a nutritionist. Now, that would be particularly important if you've got ongoing bowel-related symptoms. We've talked about, obviously, you're in there. Let's start at the top. I jumped through. So you're obviously in there, your family, your carer, and maybe not every friend, but maybe you've got some special friends. Certainly your GP is absolutely key to this who's in my health team. And you can cast your eye down the list and think, yes, actually, look, I have got ongoing back pain. Maybe that could be assessed by a musculoskeletal person, and you might need to get a referral to them. Maybe I need some physiotherapy, particularly if the pelvic muscles are spasming and they're going into cramp, or you've got ongoing pain from the groin that goes right through to your hip. Make sure you tell your gynecologist about these bits. You can itemize them or bullet them when you go to see them, so that they can be really clear and you're not being selective about the kinds of symptoms that you've got. If you've been suffering for so many years, I really encourage the patients that I see through my EP coaching, or endometriosis and pelvic pain coaching practice, to include a clinical psychologist to really help them come to terms with that trauma of all those years that they were disbelieved or not diagnosed, and really get on top of the problem so that you can address it and it doesn't become a nag, a horrible daily or regular nag in the background. And other therapists, and I like to put also organisations like Endometriosis New Zealand, like Fertility New Zealand, respected organisations that are respected by their peers and within the medical world as well. So moving on now, we've got our next slide coming up. So this is what we can look at. So we've done this bit, and we've had a look at those other management options up here. And now we're going to truck up this thing because we really want to be well. What are the kinds of things I need to do? Educating yourself is enormously important. And on both the Fertility New Zealand website and Endometriosis New Zealand, you'll find a wealth of information. Really, Googling something is scary to me because the likelihood of you finding it is quite true. And whether we don't know where that comes from or where you're going to land. So be very careful about that. Nutrition is really important, particularly if you've got bowel-related symptoms. But please, eating the lettuce leaf instead of the mescaline salad is not going to stop endometriosis. I really recommend patients to consider having a look at nutritional aspects if they have ongoing bowel-related symptoms that don't resolve from surgery. And sometimes that can be quite common in women with endo. So we can have a look in a minute, but I suggest you look at the FODMAP foods, and we'll go there shortly. Exercise. Now, what we know is this. Exercise is the best non-drug treatment for pain. And you can roll your eyes and sit there as you're cuddled up on the couch. But that means getting your shoes on and getting out the door. And even if you walk around the block, and mix the brain up next time, go around the other way. So no one is expecting you to pound the pavements. No one is expecting you to get an expensive gym membership if you don't want one. But the thing is to do something so that we're releasing those lovely endorphins. And I sometimes say these are the pain switches. And when they're hard on, we need to learn how we can turn them off, turn them back the other way. And exercise is a great thing to do that. And walking is wonderful and it's cheap. And you can get out there and natter away to a friend if you like, or walk the dog. But the important thing is that you're doing it. Look, other therapies, people come up with all sorts of things that you can do that will cure your endometriosis, and they range from everything from snake oil type products that you can rub on or ingest, but I like to talk about evidence-based things that we know work and that are spoken about in the literature, so that we've got something to base things on. If you want to try those things, that's absolutely fine. But we really deal with the evidence-based things and things that work. Mindfulness is a really good thing to practice. And now there are apps that you can download. Some of them are free. Some of them are for a very nominal amount. And you can actually practice this. And living in Christchurch, it was really important that the whole community down here after the quakes and during that post-quake period of years, you would see things like come to the laughing session at the local church. And you think, look, but it was about being in the moment, about being present, about being positive about the things that you can achieve. So have a look at those things and see where you think you could put some emphasis on and concentrate on those things. Even if you chose one tonight, that would be fabulous. So I would like you to get that thing in your mind now and say, that's what I'm going to do, and put some exclamation marks next door to it. There's a huge burden of undiagnosed patients with endometriosis, and mostly it's very young girls. And I bet some of you listening this evening will be able to remember that you may not have been diagnosed till you were older, perhaps in your 20s, even 30s, but you remember those periods when you were 13, 14 and 15 and how much they affected your schooling. So let's move on and have a look now at the next slide. And we can see here that what is chronic pain? And I sometimes tell my patients here that if the pain is sort of centered around in the pelvis, let's say the pelvic area is the driver of the pain, that shoots some text messages off up here to the brain. It's the sorting station. It's where it says, I can biff this out. I don't need to worry about it. Or hang on a minute, I've heard this before, and yep, I really do. And it fires, so the pain comes up through the spine. They're little text messages that pop up through here. And then you get a text message back saying, yep, I've registered that, I've got it. If you are living in chronic pain, as many people with endometriosis are, and you throw in some extra things like, now my fertility is affected, that has a dramatic effect on your general well-being and your mental health and your productivity at work and all sorts of things. So if we take that slide a step further and look at this, you can just quickly whiz your eye around these things. The driver of the pain, all I think about now is how bad it is, and I feel quite hopeless, and now everything is affected, my sleep, sex life, friends, even my fertility, and I hardly go out. So some of you listening will be understanding that feeling of isolation when you are just feeling like not wanting to go out with friends because you're always sick and you feel like everyone's over you in a big way. It affects mood. And then we come down here and then we get feelings like that burning pain, bloating. And often a doctor might now tell you that you've got central sensitization. And so you can look up that as well with Endometriosis New Zealand, where it almost like everything is on red alert. And that is incredibly stressful. So if we have a look at the what can we do then? The one thing, you've chosen the thing that you're going to concentrate on, and tonight it might be nutrition or it might be exercise. But the next big thing I want you to work out is focusing on the things that really matter to you. Like, what is that about? Well, my doctor says, for instance, that I need another surgery, but I've already had 7 or 5 or 4, or what's the next one going to do? And is that going to be any better than the first one? What about I'm having my 17th procedure? So we really need to work out what is important to you. Let's talk about fertility, because that's what tonight is all about. If it's about fertility, that's going to be your area of concentration. And so I would imagine that you've already found your way to a specialist, a fertility specialist. And if they wear 2 hats like endometriosis and fertility, you've really struck the jackpot. Thank you, Neil. So I think that is excellent when you work out what your goals are, because quite often they're a little bit apart from what the clinician's goals are. And then you also think, you've got your team together, remember, and you've got the things that you're going to do. So here's some ideas too. So some of you might be jotting these things down. Yep, I know that I'm going to have an MDT approach, is a multidisciplinary approach. So the other members of the team are going to pop in there. And in the interest of time, I'm going to move quickly on. Nutrition. Now, I'm not going to go through all of these things, but this is a screenshot of a page on the Endometriosis New Zealand website. You can pop in there yourself. If you've got another device apart from your computer, or you're really quick with your phone, you can zoom into nzendo.org.nz now, and you'll be able to see what can I do that's evidence-based. And it's interesting with some more research that's happening, just released in Australia this week. They're putting more money into several projects. One of them is finding out more about the relationship with FODMAPs and endometriosis. So we've been working with FODMAPs for some time, and many women find that by looking at the FODMAPs and excluding those foods that really irritate your bowel, and there's something you can work out. It may be something that you can do before you go to a dietitian, or you may not need one if you can work that out. I'll show you where to get some more help about that. So on we've got a group called ESIG, which is the Endometriosis Special Interest Group, and that comes under the umbrella of Endometriosis New Zealand. Every month we put a question out to our ESIG members, and they range from experts in laparoscopic surgery, gynecologists, wonderful GP, through to pelvic physiotherapists, researchers, and so on, a wide range of allied health professionals. The page looks like this. You can scroll down from the page and find all manner of things. You just need to be patient and work through. And we've just loaded the June file today, and the questions, these are all patient questions, and June's question focuses on fertility. So it's beautiful for this presentation tonight. So ESIG, ask ESIG or ask an expert, and that's where you'll find it on the Endo NZ website. This is a screenshot, once again, of what those files look like. You can see back in May, the questions from patients was, what should I do if my doctor doesn't believe me? And these are answered by expert gynecologists and health professionals, and they're being really honest in answering questions. So that's a great thing for you to go into and look at. I'm going to ask you a quick question here. This is Laura, and Laura's 15. Lisa's 33. Who had the worst pain? And we won't linger, but I can tell you that no one can tell, because what we know about endometriosis is that the stage of disease doesn't equate to the amount of pain that someone experiences. So Neil showed you these images of stage 4 endometriosis that Lisa had. Certainly the surgery is much more complex. The treatment is much more complex, and I can tell you that, knowing Lisa, that she had a major fertility problem. It was a 2-stage procedure, and I can tell you now that she's had her second baby conceived naturally. So that's a lovely story as well. Little Laura was only 15, and this pelvis looks entirely normal, but endometriosis was found. This, in fact, was her second procedure. And at 13 or 14, she was unable to go to school. Her symptoms were so bad. So we can't tell who had the worst pain. And I'm saying that to those of you who have got perhaps mild disease and are feeling like your pain shouldn't be that bad, or you've been told it shouldn't be that bad. So what we do want to do is recognize the symptoms early and diagnose early, so that we hopefully stop this from becoming this in an advanced stage disease. So the motto of Endometriosis New Zealand is strength through support. Mā te tautoko ka whai kaha ka ora. And I'd like to thank again Fertility New Zealand and Nicola and Neil. It's been really lovely bringing you this little wee snapshot, really, of the things that you can do, but where you can go and get the help you need. And you're a pretty resourceful lot. I know that you'll be there. Thank you.
I'll just go to a question now.
Good questions. Do you want to answer those questions first, Deborah, from your perspective, or should I fire away?
Oh, I think you fire away on that, and I'll pop in.
Okay, so it's a common worry for women who have endometriosis, Samantha, that when it's been nicely controlled with medical treatment, and one's looking to come off medical treatment, which, as I mentioned earlier, is almost always contraceptive. You've got to come off treatment. How's that going to go? Well, number one, very commonly you will have a sort of a honeymoon phase after coming off treatment, where there isn't a great deal of pain. And indeed, some women's endometriosis, after a lot of years, doesn't cause them as much pain as it once did. So it's not necessarily destined to come back. So that's good news. But there are women who, when they stop medical treatment, the pain does gradually come back, and sometimes the endometriosis, which has been held by the hormonal therapy, can also come back, and that can be a problem. The good news is, yes, you're right, that when you're pregnant, usually the pain of endometriosis does subside. Not always, but it does. But yes, there can be a limited time window in which you have a limited time to become pregnant before symptoms can start to recur. So I talk to a lot of my patients who have this, very real concern about the time window, and perhaps it might be good for you to talk to a specialist or your specialist, certainly a fertility specialist, about, look, what's the plan? How long do I give it naturally? Do I give it 2 or 3 or 4 or 5 cycles naturally, or do I move in a bit more quickly? Should I be considering, if I'm not pregnant within 3 or 4 cycles, maybe having a Lepardol procedure? Maybe after that, alternating natural cycle attempts to conceive naturally with IUI. And if at the end of all of that hasn't worked, maybe looking at something like IVF. Might I need another surgery? So all of these options are open to you, but maybe you have a bit of insight already as to how quickly endometriosis pain came back before, if that's something that you've tried. But on the other hand, maybe you have nothing to base that on. So I think a good full thickness discussion along those lines with your specialist would be a good plan. Do you want to deal with the can endometriosis grow back, Deborah, from
well, I can certainly talk to it, but you'll probably what we know is that endometriosis can recur. Now, I guess there's a debate about whether it was excised or fully removed properly in the first place. And I think that probably is the question that would be really good. Sometimes in these cases, it might be a good idea to seek a second opinion. And certainly a very good idea to have your notes fully explained to you so that you understand exactly what was done. And that might be your GP. That's something I certainly do in the private work that I have with my patients, to make sure that we're starting from a point where endometriosis was excised or resected or removed by a specialist. So if it is recurring then, or was it not removed in the first place? I think that is a really good point to establish. And then the next thing is that I think the thing that we have to get our head around and really understand is that this recurring pain is not always because, oh, my endo's back. It could very well mean that when I was talking before about the chronic pain that exists, and that maybe you're going to have that really good discussion with your specialist about where those pains are and how each of those things might be managed appropriately before we just dive straight back in and do more and more and more surgeries. Because what we know now is that multiple surgeries isn't necessarily the answer. Neil?
That's right. I think most of our data suggests that it's about a 50-50 thing with a good surgery as to whether that will be potentially curative or whether it will still come back even after good, a thorough laparoscopic excisional procedure. But I mean, you're absolutely right, Deborah. Seeking the opinion of someone who is a surgical expert with regard to managing endometriosis, and as you said before, looking at what your goals are. Is the goal a fertility goal? In which case, as we've said already, pregnancy can be helpful towards a bit of symptom control sometimes. But or are we looking to really to get rid of all endometriosis and to manage pain? So again, looking at goals. Why are miscarriages common with endometriosis? Now, that's an interesting one, because up until about 5 years ago, we didn't know for sure that endometriosis was really associated with an increased risk of miscarriage. We've known for a long time that it was associated with an increased risk of ectopic pregnancy, but the data that very clearly there is an increased risk of pregnancy loss with a history of endometriosis, we've only known for a relatively short period of time. Why? Good question. I don't know that we really completely understand it, but it is probably due to we talk a lot about the immunological environment with regard to endometriosis, both within the pelvic cavity, but also within the uterus itself. And there's quite a bit of overlap with endometriosis and adenomyosis. I happen to think that adenomyosis, which is the endometriosis of the wall of the uterus, we talk about endometriosis being endometrial type tissue found outside of the uterus, but adenomyosis is that same condition, but where it's found within the wall of the uterus. That probably affects the functionality of the uterus itself more than does endometriosis, and it is probably the overlap between endometriosis and adenomyosis that can expose women to an increased risk of pregnancy loss. What I would say is that it, although it does increase the risk of pregnancy loss, it doesn't increase it massively. So it's not quite a doubling, I think, of the chance of pregnancy loss. So it doesn't double the chances, but it does somewhat increase the chances.
So you saw me dive down into the bookcase down there. This is a book that was written by Susan Evans, and I've added some bits to it. It's available through Endometriosis New Zealand. I don't reap any royalties from the book, by the way. All the royalties go to the organisation. But it's a fabulous bedside resource for you to have, and it does talk about fertility in here and things that you can do for you, and it really spells things out quite plainly and easy to understand language. It's a great little bedside read, actually, just to have in the bookshelf if you wanted it. So endometriosis and pelvic pain. I'm just raising that now for your interest.
Samantha, you're asking some very searching questions here. So you said that you've had a laparoscopy a few years ago and want to try for a child. Does that mean that you won't have any troubles getting pregnant? Ooh, fertility's a complicated thing. I don't think anybody would promise you that. I suppose maybe the nature of your question is, could endometriosis still have a negative impact on your fertility? I'll reframe your question. It could, because it can be a recurrent condition. Might you need the operation again? Well, you might, but the chances are probably not, and hopefully not, especially if the endometriosis at the time wasn't affecting your fallopian tubes and ovaries. Actually, we've got an interesting thing now called the Endometriosis Fertility Index that I like to do this score on all of my patients who have laparoscopic surgery for whom fertility is potentially a future interest or an immediate interest. And that gives you, so if your specialist hasn't done that, it might be worth talking to someone who knows about the Endometriosis Fertility Index. And that can actually give you a guide as to what is the chance of you just becoming pregnant naturally by doing nothing else over a certain period of time. So that's the EFI, or Endometriosis Fertility Index. And most women who are young-ish, whose fallopian tubes and ovaries have been relatively unaffected by endometriosis will score pretty high over the chance of getting pregnant naturally. Might one need the operation again? Well, we know that second surgeries aren't as helpful typically, A, for pain, but B, also for fertility. So one perhaps wouldn't be racing into further surgery, although it is an option. And some women, do struggle to get pregnant unless their endometriosis is fully and comprehensively removed surgically. But don't forget about the other options that we talked about from the fertility perspective: Lepardol, IUI, IVF.
The next one by Celeste is definitely yours, Neil.
Okay, so beginning IVF, Celeste, later this month after endometriosis-related fertility delay. How come this is the first we've heard of the of the Lepardol? Oh dear, sorry. Okay, well, Lepardol, we've been okay. So our New Zealand data on Lepardol we knew about in 2004, but a lot of specialists thought at that time that was a fairly small New Zealand study and the data needed to be replicated. And unfortunately, it's taken over a decade to replicate the data, and the Dutch have done it now. Having said that, the Dutch didn't particularly look at endometriosis-related infertility, so ours is the only data set that has looked at the value of Lepardol for endometriosis-related infertility. Look, you know, I mean, I personally think that all fertility specialists should be discussing this as an option with their patients. But the reality is that not every fertility specialist believes in this. Surprises me, because to me the data are very clear cut. I didn't really present the data comprehensively tonight, but if you saw the data, I think you'd be impressed by how the data look with regard to fertility improvement with endometriosis. So, yeah, I mean, I honestly think we should be spreading the word about this, and I think that it should be part of the discussion. And therefore, I think that if you are going through fertility treatment, you probably should bring it to the attention of your fertility specialist if they're not bringing it to your attention, and to ask them about it. Yeah, so sorry you haven't heard about it till now. I've done my best to promote it, but for a decade I felt like a voice in the wilderness. Not so anymore, because the Dutch produced a lovely study that supported it. But yeah, sorry you didn't hear about that before now. But it remains an option, and even if, you know, for the future, even though you're perhaps on a trajectory for IVF, it should be borne in mind for perhaps another time. Sophie.
So I was just looking at your question, Sophie. One of the things that I can, with all of you watching tonight, might be interested, if you go to the front page of the Endometriosis New Zealand website, and where it's got about endometriosis, and scroll down, you'll come to something called videos. In the videos section, there's a wonderful little 7-minute clip from Dr. Janine Brown, who's an endometriosis specialist and fertility specialist in Christchurch. Also, there's an interview with Neil on fertility. So you'll find a wealth of very small 2-minute videos there, and other videos that you might want to click on and have an interest in, depending on what your interest is this evening. But the one on Janine Brown and fertility is particularly good. She'll teach you about the 5 F's, and I think you'll find that quite interesting. And really, it talks there about, Sophie, about your egg reserve in that little 7-minute video clip. So that might be something you want to look at. Apart from that, Neil, it's probably yours too.
Yeah, look, Sophie, I think it's a good idea when specialists don't operate aggressively on the ovary when ovarian reserve is a concern, as in your case. So I think that's a good idea. And I think the fact that a little bit is left on the ovary probably isn't a great big deal. And probably that does you a favor in the long run, in terms of not negatively impacting the ovarian reserve. But it is a fine line. Probably the fact that a wee bit was left on the ovary doesn't influence greatly whether the endometriosis comes back with a vengeance or not. In most cases, it does not. But there are, you know, a minority of cases where endometriosis can recur aggressively. You know, perhaps this is the moment to be thinking about other options, as we were discussing Lepardol and IUI. Certainly, it's not such an expensive treatment option. So the option of combining Lepardol with, you know, trying to conceive naturally, perhaps alternating that with IUI in the waiting time between surgery and IVF, isn't a bad idea. So, Jackie, are you? Deborah, I'm sorry, I'm busy answering the questions, and I'm not really keeping pace. So, do you have any comments about this, Deborah, from the experience of many of the women who who avail themselves of Endometriosis New Zealand's experiences. So, Jackie, you're
talking about
25.
the starting, needing to have an actual diagnosis. Are you talking about that?
So sorry, just Jackie's saying she's 25, diagnosed with
stage. I'd moved on to Nicole. I'm sorry.
Sorry, stage 2 endo 2 months ago and had it excised. Is it better to try for children early or wait till you're ready, even if that is 5 years away? Ooh, go on, I'll let you answer that first, Deborah.
I don't think there's any hard and fast rules here. But what I hear, and we hear specialist gynecologists saying frequently, is that the sooner rather than later is a really good option. The question is what's sooner and what's later. And I think that when they diagnose endometriosis, they might have a really a genuine discussion with you about your fertility and about the fact that endometriosis is certainly one of the contributing factors of making it more difficult to conceive. So they might talk to you about that. Now, I think that's personally a good idea, because then you can have a plan in place. You'd be 25 if you were now 39 and you thought, great, now everything's right, we've got everything set and now we can have the baby, and things don't happen for you. Wouldn't it have been, if you just thought back, why didn't somebody say to me when I was 25? Why didn't somebody have that plan in place to tell me that sooner rather than later is probably a good idea? 25 is still quite young. I think we'd be talking around about, certainly under 35, but around about 30. But it's quite brave of people to actually put an age marker on it.
Jackie, I mean, that's exactly right, Deborah. But Jackie, I think it's also quite helpful to think about other aspects of your fertility. And sometimes it's a good idea to have your ovarian reserve benchmarked, because we know that there is overlap between endometriosis and its impact on ovaries, and even just subtly endometriosis and its overall impact on ovarian reserve or egg reserve. So having an AMH level, an anti-Mullerian hormone, just a blood test, and knowing where you are on the centiles with regard to ovarian reserve can inform decisions about, how urgent is urgent, how sooner rather than later would I be best advised to, I mean, I'm always loath to say to women and to say to couples, look, have a baby now. But, if it's an important life goal, and you've got extra information about ovarian reserve, one of the issues is that about 1 in 10 women in their early 30s are struggling to get pregnant on the grounds of low ovarian reserve. And so, and overrepresented within that group are women with endometriosis. And I think that's not commonly known. So I hope that helps. But maybe a good discussion, if your gynecologist doesn't have a high level fertility expertise, perhaps even a consultation with a fertility specialist at this time is not a bad idea. Look, we offer telehealth through Repromed if you're not Auckland based.
Neil, I'm just going to interrupt. I'm going to ask a question now, because it was something that I wanted to, we talked about yesterday. And that is that we talked about dietary things, supplements, and you would recommend that your patients would be taking folic acid and
iodine.
Iodine, yes.
Yeah. I don't think we recommend any other particular supplements that are anti-endometriosis or recognized as being anti-endometriosis supplements. Quite right, Deborah. Yeah.
And I just thought that might be helpful for some of these questions coming through to hope that some of these women who are trying to conceive are taking that.
Yeah. Now, I'm just mindful we're quite short of time, and thanks for the message, Nicola, but I think you've given us license to try to answer the questions that we have here. So I'm just going to move on to Nicole. Is there any correlation between endometriosis and low AMH? Well, yes, there is. In a patient with very low AMH, suspected endo and frequent pain, is IVF their only option? No, it isn't. But IVF should be considered maybe high priority, because in a year's time in this context, maybe the response to IVF might be not as good as what it is now. But it's not the only option. And for women with low ovarian reserve, particularly where the fallopian tubes and ovaries are relatively normal, where there is a chance of conceiving naturally, then again, Lepardol for the fertility boost and the month-on-month opportunity to conceive naturally will often yield the results that one's looking for. Perhaps even surgery, but obviously care to avoid aggressive ovarian surgery. And just to say that, pardon the pun, but putting all your eggs in the IVF basket. So in any one given cycle, if the ovarian reserve is low, sometimes there can be not even necessarily a good quality egg in a single IVF cycle. So IVF is not always the ultimate panacea here. And I think one needs to have a discussion about the full range of options. Emily, can surgeons see signs if you're likely to be infertile or may struggle conceiving during a laparoscopic surgery? Yes. If there's, as Deborah mentioned, if there's stage 4 endometriosis or severe endometriosis, and particularly if it's affecting the ovaries and sticking them down, causing adhesions, causing cysts on the ovaries, and perhaps even damage to fallopian tubes, then very clearly that would be an indication that there could, that there almost certainly would be some fertility issue. But endometriosis can affect fertility in quite subtle ways. We've talked about ovarian reserve. Even women with stage 1 endometriosis, and that's, I don't like to talk about minimal and mild endometriosis because I think that's a bit rude, because as Deborah says, the symptoms, I think we should move away from talking about minimal, mild, moderate and severe endometriosis. We should talk about stages and recognize that the stage has no relationship to the severity of the disease being how painful it is, and how much it or how likely it is to cause infertility. But there is some overlap between the stage of endometriosis and the likelihood that it causes infertility, even though that's not the case in terms of the severity of pain. But as I've said, even the most subtle of endometriosis can halve one's per cycle chance of conceiving naturally. And I think if your surgeon has said after laparoscopic surgery that she thinks you should be able to carry a child, what would she see to think this? Well, she would presumably see that your fallopian tubes are normal and may well even have tested them with dye to make sure that there's no blockages. She would have seen that your ovaries are relatively normal, and she would see that there wasn't a lot of residual endometriosis, and hopefully would have seen that your uterus is not significantly affected by adenomyosis.
I think that's what I was just looking at that too, Neil, and I think she would have seen that after she excised or removed the endometriosis, that the anatomy is normal, and that there's no adhesions, sticking bits up and pulling bits to other bits that is all stuck down. So she would have seen anatomy that now the endo's gone, looks quite normal, and everything's in the right place.
Ange, sorry, were you going to ask, Deborah?
You go, Neil.
I was just going to move on to Ange's question, because I think that is the last question, and I hope that that Deborah and I have endeavoured to answer everyone's questions. We may not have covered it all, and look, I'll be very happy if somebody wants to approach me with a secondary question at some point. Very happy to cover that. But Ange, you said you have stage 4 endometriosis, trying to become pregnant for 2 years. After 3 laparoscopic surgeries, on the waiting list for IVF. Oh, I'm sorry, suffering regular miscarriages. Yeah, it's tough, isn't it? Would I recommend trying Lepardol? So look, we do not really have any clear data on whether Loperidol reduces the chance of further pregnancy losses in the context of repeat pregnancy loss. We know that it improves endometriosis-related infertility, and I have had patients in your situation who've come to me, and in this very situation actually, who've asked me to undertake a Loperidol procedure, and often it does work out for them. That does not mean that we can be clear that it is an effective treatment, because we just actually haven't got the study, we haven't got the proper trial to really show that. But we know that Loperidol exerts some immunobiological effect that is positive for fertility, for the fertility of women with endometriosis. We've talked already about pregnancy loss in the situation of having endometriosis being an immunobiological problem. So, it's a relatively low invasive procedure. What I would say is that one would hope that the stage 4 endometriosis wouldn't have caused any damage to your fallopian tubes, and I presume that it hasn't, because I'm guessing at this point that the pregnancies that you've had are naturally conceived pregnancies, and therefore that your fallopian tubes are functional. And in that situation, to be honest, and look, you have to take this with the knowledge that I'm particularly committed to Loperidol, because I wrote my MD thesis on it. I've been researching it for 20 years, and it is a little bit my baby, this. But I am very impressed. I remain very impressed with the results of Loperidol treatment for women with endometriosis in relation to improving the chance of a successful outcome. What we don't have is clear information that it reduces the chance of further pregnancy losses. The other thing that I would say is what you could do with IVF is to look at having pre-implantation genetic screening of the embryos. If you're having IVF, you can have them assessed chromosomally before the embryos are transferred. So that's another opportunity to potentially lower one's chance of further pregnancy losses that are related to embryo chromosomal issues. I hope that's helpful.
Neil, is Loperidol available anywhere else in New Zealand?
I think it's probably becoming available in other places in New Zealand, but I suppose it's like we were saying earlier. I guess competitor clinics haven't been necessarily convinced of the data around Loperidol, and therefore it hasn't really been launched. I think within a year or two we'll see it available in every major city in New Zealand, and actually in every major city in the world. That's what's happening at the moment. But at the moment, there are different places in Auckland that you can get it done through. So Auckland Radiology Group offer it. I do these procedures at Auckland Radiology Group, 2 doors down from Repromed. I believe Ascot Radiology offer it. And certainly there are radiologists around the country. There's a radiologist in Tauranga who... there's my son making a guest appearance. Good evening, Tim.
I'm just using the printer very quickly.
I can tell.
My fault. Apologies.
So there's a radiologist in Tauranga who's interested in this, and I'm certain that radiologists and fertility specialists in around the country, throughout the latter part of 2020 and the next year will be offering this.
That's good.
I think we're done for now. So I just wanted to say an enormous thank you to our wonderful presenters tonight. Deborah and Neil, thank you so much for sharing all your amazing expertise with everybody. Just so you know, the recording will be available on the news section of the Fertility New Zealand website, and I'm sure Endometriosis New Zealand will make it available as well.
Thank you, Nicola. Yes.
So thank you everybody for joining us tonight and for taking time out of your evening, and also for your wonderful questions.
Yeah, fantastic questions.
Yeah,
it's
thanks,
really not
everyone.
easy, this, and we don't get it right all of the time, but we're doing our best.
And we have an endo help service too, that you can book a clinic and book a time to have a 30-minute free chat. So that's available to you.
Thanks, Deborah.
Yeah.
Please do reach out to all the help available.
Thank you, Nicola, and to Fertility New Zealand. It's very good.
Yeah, Nicola, thank you, and thank you all for joining.
Wonderful. Good evening, everybody. Take care. Thank you.